It's usually something that's quite acute. They've got the patient in the clinic with them and they just want some guidance on a complex area. Obviously the vast majority of decisions are made without referral to anybody apart from themselves, but just somebody that's a more complicated patient, elderly, multiply comorbid, something new has happened, we both have known the patient, they'll phone up and discuss, and you know, I welcome that. I think that's sensible, because they can be difficult decisions and you can often make them together. I think that what I've seen is that general practice, they have grouped together more, and I think from their perspective that must be a relief to have more colleagues around them so they can share ideas and discuss difficult issues, and also the sort of on-call and holiday relief, you've got other people to help. And I think I've seen that, and so I'm hopeful that that will give them a better lifestyle and more support at work, because everybody needs support from time to time. The danger of that, if the practices become too large and you lose the patient-doctor relationship, which is all important. Every patient has got their doctor, and that's one of the keys of medicine. So somehow in those larger groups you've still got to be able to have your own patients that you largely see. But that's what I see, and I see that as a positive, and bringing in pharmacy support, radiology, even dental support nearby, I think that's positive for them and also for me as a consumer. That's what I want as a patient of a GP. Well, I think I sometimes wonder if colleagues think that you know, everybody drives a Maserati, which I don't. Wife, mortgage, 4 kids, and it's a Holden Commodore for the record. I think people know that you're busy. Probably colleagues in general practice, you know, don't always remember that you're there. You take your share of the weekend call, you know, the night call. You know, 2 in the morning chest pain is not. It has to be dealt with. You get up and deal with it, but it's not particularly welcome. And so, and I know that general practice does that as well. In medicine, we all do that. I think that misconception is that everybody is a Flash Harry, and I don't think we are. We're just normal people trying to do our best. I think there's several areas of rapid advance. I think wherever there's an area of rapid advance, there's still the basics in that area which can be covered for the majority of patients. So we could pick the rapid advance in electrophysiology with the use of ablation. Now that is not the cure-all. For most patients they don't need it, but it certainly is a rapidly developing advantage to a minority of patients who can get good treatment in that way. Another area particularly interested or catches my interest is the whole area of prevention, and that's probably because I am now middle-aged and I see the illogical approach of getting up at 2 in the morning fixing people when if only you could have prevented a problem, it would be a lot more sensible thing to do. So the way that we try to assess risk and then more proactively manage people, I'm fascinated by that, and I think there's a lot coming through there. Calcium scoring, CT scanning, I think that's an area as well. But in both of those areas, EP and in prevention, the basics are still key. Encourage people to lose weight, stop smoking, take the pills before you get too fancy. I think areas where it's doing the basics well, which I think it pays dividends. One of the areas is taking a blood pressure. So I'm lucky because usually when I'm taking blood pressure it's before a treadmill, and so our nurse will take the blood pressure both lying and then standing, and I'm amazed at the extent of the postural drop in many older patients, and I never did that in my own clinic. I'd never lie them and stand them, or very rarely, and I think just doing that well in elderly patients to keep an eye on their blood pressure is enormously helpful. I think an ECG is a very useful tool. I personally think every adult should have an ECG as a baseline, and then you can compare it in later years if there are changes. I think that's very helpful. There's a slight, I'm not sure where it's driven from, but sometimes there's a reluctance to do repeat blood tests, and I actually see blood tests as a cheap manoeuvre. Going to hospital or getting sick, that's an expensive outcome. So I think we could possibly do a few more blood tests, looking for areas like thyroid dysfunction, anemia, and so keeping things simple and doing them well. I wouldn't tell anybody what to do, but I think that's what I see as what makes somebody a good doctor and valuable to patients. I think the relationship on a one-to-one is fine. I think we respect each other, and I think we get on when we meet each other. I think the processes between particularly big hospitals, outpatient departments, and the general practice is terrible. There are delays in getting letters out, there are delays in transmitting ideas, and it's in this day and age really it's a hurdle which should be able to be overcome electronically or other ways. I think that's one of the big faltering areas of our health service, which overall is an extremely good health service, but where we could really improve is the hospital to general practice, the secondary to primary communication, which is unbelievably slow and archaic and difficult. I think it's an element of IT. It's also an element of making sure that the hospital's got the money that it's given in the right areas. You've got to have a competent typing pool where letters can come out within 2 or 3 days. Waiting for 2 or 3 weeks is simply asking for trouble and bad healthcare. So it's both IT and also understanding what makes good medicine. And if you look at it from the patient's point of view, it's pointless going to a clinic and then your own doctor, your doctor, doesn't hear about it for 3 or 4 weeks. I mean, that's just hopeless.